Welcome to Practicing Failure, where we learn about mental health, celebrate mistakes, and explore how failure helps us grow. I'm your host, Dr. Amanda Castle, and I'm excited to introduce my guest today, Dr. Brittany Booth. Dr. Booth is a board-certified, UCLA-trained adult psychiatrist with a special focus on treating people during reproductive transitions such as pregnancy and postpartum. She earned her bachelor's degree from Boston University and her medical degree from UCLA. She also completed her psychiatry residency at UCLA, where she served as the chief resident of inpatient units and chief resident of the Women's Life Center, a world-renowned center for reproductive psychiatry. In addition to her private practice, she is the associate director of the Women's Life Center and sees patients at the UCLA Maternal Mental Health Intensive Outpatient Program. Welcome to the podcast, Dr. Booth.
Thanks for having me. I'm
excited to talk to you because psychiatrists come at the world of mental health so differently than psychologists, but we're co-treating a lot of the same things. And then you have this unique lens on reproductive mental health, which is just so wonderful because there's so many ways that physicians don't know what to do with hormones. And so they kind of
absolutely
just avoid them, which I get. But you're not only treating them clinically, you're also helping contribute to the research, which just warms my heart because that then allows other people to take that and start integrating it into their practice as well. So thank you.
Yeah.
All right. So probably a helpful first place to start would be clarifying how psychiatry is actually different than psychological therapy. So what do you see as the role of a therapist versus the role of a psychiatrist?
Yeah. So as you mentioned in my bio, I'm a psychiatrist. I went to medical school. I did residency, right? So the main difference is that psychiatrists can prescribe medications or offer other kind of biological interventions like TMS, which is transcranial magnetic stimulation, or ECT, some of these other things. That's the main difference. Some psychiatrists do therapy. We get education and some training kind of about therapy, so we learn about CBT and DBT and other modalities. And some psychiatrists in their training choose to pursue some further experience and certification in it. But compared relatively to the training that therapists, psychologists receive in the psychological sciences, we don't get nearly as much.
Yeah.
And so I almost think about it as treating the hardware versus the software sometimes.
Oh, I like that. Yeah.
Psychiatrists can treat the hardware, the organ of the brain, and make sure that things are firing on all cylinders, or at least the way that they need to, enough that the software can be improved and tinkered with and worked on with therapy.
I love that. And yeah, that's really helpful because I know the words are similar, and people who haven't been to med school or grad school, there's no reason they should know the difference.
Oh, yeah.
Yeah. But yeah, hardware, software, super helpful. So when you're first meeting someone in the midst of a reproductive transition, how are you sort of approaching that and assessing what's going on?
Part of it is just understanding the experience and the lens of where they are in life, and that it's not just hormones that are changing in these transitions. It's psychological things too, right? It's role, it's identity, it's the experience of being a woman or a non-binary person or a trans person, going through these transitions, which is just a different experience than being able-bodied, cis-het, white male, right? Which is what most of the research is done on. And so part of it is just the lens of understanding the lived experience of these folks. But part of it is also understanding that hormones can play a role in how mental health is sort of presenting itself. A lot of it is looking at timing of symptoms, right? Are symptoms coming on? Is there onset or duration or pattern of symptoms looking like a picture where hormones are playing a role? Like, is this the menstrual cycle having an effect? Or in the postpartum, did symptoms come on in those first few weeks when that hormone crash is happening? Or, is a woman or a person who has had maybe some symptoms or no symptoms throughout their life all of a sudden in their 40s or 50s, all of a sudden starting to have symptoms is perimenopause. What's going on here?
Perimenopause.
Lovely perimenopause. And so it's kind of looking at the pattern of symptoms and not just going like, well, you have depression now. It's questioning why now and if hormones are playing a role in that.
I imagine that really changes the approach that you take biologically if it's a transient shift in the body as opposed to a state that's been fairly consistent over the lifetime.
Mm-hmm. Yes and no.
Okay.
Interestingly. And I think that is likely to be the case going forward as more research is done, as more targeted hormonal treatments are available. Because sometimes it is, people think the answer is measuring hormone levels or adjusting estrogen, progesterone, etc. Sometimes, not always. So even when mental health is being affected by hormonal transitions, we oftentimes will still fall back on the same treatments that we use, just understanding that there is this extra influence. Mm-hmm. But we are starting to think that way. And so, there's a newer medication specifically for postpartum depression that came out a couple years ago. That's a 2-week course of medication, knowing that, and it's a hormonal.
That's incredible.
Analog. Yeah. So, if somebody has just no mental health history, they just get depression in the postpartum, this medicine might just kind of nip that in the bud and they're fine. They don't have to commit to a year of SSRIs or something.
Yeah, I found with some of my clients when they're going through those transitions, it can take a while to find the right SSRI.
Yeah.
And pregnancy and postpartum is not always long enough to account for that. And so it can feel very, I think, defeating to people of like, well, why try if this is a short window and it may not help anything in that time? Mm-hmm. So what a beautiful resource.
Absolutely.
So in the course of developing these symptoms and not knowing what's going on, when would you advise a therapist or a patient to bring medication consultation with a psychiatrist into the picture during this time?
Yeah. I think if the symptoms are severe enough to be causing impairment in their functioning in any way, right? Struggling to function at work, can't take care of themselves at home, can't take care of, children or whatever at home, having any kind of thoughts of harming themselves. Mm-hmm. When it reaches the sort of severity threshold, I think that absolutely is an appropriate time to bring medication in. Even when it's sort of a moderate severity, right? Mm-hmm. If the symptoms are getting in the way of the person being able to engage in the therapy that they're in, that's another time, right? So even if they're not having these horrible thoughts, or even if they are sort of, they're functioning-ish, quote unquote, day to day. But I sometimes will phrase it as they're so focused on putting out the small fires week to week with their therapist that they can't ever gain any traction or momentum in therapy and start doing that bigger picture or that deeper sort of work. That's when medication can be super helpful. It can lower the volume of anxiety, right? Lower the intensity of depression so that week to week when they're meeting with their therapist, it's not just spending that whole time talking about, oh, this happened this week and I was so anxious about it and I spent this whole time in doing the grounding techniques and all of that. Those little fires aren't happening, or they're much more manageable, and they don't have to be the focus of each therapy session. And so you can start to identify the patterns that are contributing to it.
Yeah, you can go a little deeper into the software.
Exactly.
Yeah.
Exactly. So I think those are times when meds can help.
Yes. And I want to say a special encouragement to all of the high achievers out there, the high performers, where like they are still functioning, but they are very good inside.
At that. Yes.
Yes. And so your ability to care for and engage meaningfully with yourself is also something that needs to be taken into consideration.
Definitely.
Yeah. So you are such a great resource. I've referred multiple people to you and you've done great work with them. But I also am aware that I live in LA and have access to a lot of really robust medical options. So for people who are in areas maybe that are less dense with psychiatrists, or people, they have access, but maybe they're not reproductively informed psychiatrists, how might they be able to optimize the care that they actually have access to?
Yeah. That's a great question, and unfortunately a really common problem in this very fractured healthcare system that we have. I can speak more, towards resources for reproductively informed mental health.
Great.
So there may not be a reproductive psychiatrist in your town, your state. Hopefully there is at least one. Most of us are doing telehealth still, so if you have access to the internet and you can get in with one of them over telehealth, great, right? If they're serving an enormous population and it's just them, the wait time might be really large or might be inaccessible in some other way. And you may still have to see general adult psychiatrist who doesn't have that training, or a primary care doctor, or some other prescriber. But if you are in the middle of a reproductive transition, particularly pregnancy or postpartum, there are some really amazing resources. There's an organization called Postpartum Support International that does amazing work, and they have a perinatal psychiatry consultation line.
Ooh.
So, yes, so good to know about.
Yes.
So any prescriber can call or email or something, this consultation line, and talk to a reproductively trained psychiatrist and say, I have this patient, they're pregnant, they're on this regimen, how can I optimize this? Does anything need to be stopped or changed? And get real-time, live advice on this. There's also a written resource, womensmentalhealth.org, which is the website for the psychiatry department, or the reproductive psychiatry department at Mass General. And they have this amazing blog where when a new study comes out about a medicine in pregnancy and new safety data, they write a blog post about it where they interpret the study and then integrate that new information with the existing base of data that we have so that we know how to think about it and how to integrate it. Does this change our thinking? Does this just reinforce what we already know about this medicine, right? So huge, huge resource that I use all the time.
I love when experts sort of translate for the rest of us. What does this science mean? And how do we take it away from this something meaningful and useful in our daily life?
Yeah.
So then people can bring those resources to their psychiatrist and say, like, I think this might be related to hormones. Would you be willing to visit this research or contact it and get a consultation?
Exactly. Yeah. And I think especially in pregnancy when there are so many prescribers who, like you said at the beginning, they don't know what to do with hormones. Yeah. They don't, especially pregnant people, they do not know what to do with pregnant people. And they're scary. And they are coming from a place of good intent. They do not want to cause any harm. They also don't want to get sued. But
yes, that is a big motivating factor.
But they really don't want to cause harm. And they may not know if the meds that they're prescribing are going to cause harm to this new embryo or fetus. And so the gut reaction is, stop all your medication, right? And we know that actually can cause more harm than good. And so I think when people become pregnant or are planning to become pregnant, it's always good to do this work prior to conception, to bring these resources to your prescriber to say, before we knee-jerk stop things, let's make sure that that's the right call.
Mm-hmm. It can be very scary having to go off medications prior to getting pregnant. It's a very personal and difficult choice that nobody gets to have an opinion on except you and your doctor.
Yes.
Yeah.
Yes.
All right, so let's talk about failure, because has a unique flavor in reproductive mental health. So we're going to talk both about the subjective experience of failing, but also I want to touch on this concept of failing a medication, because that's a term that physicians will use. And so what does it mean to fail a medication?
So it means that a medication either did not work for a person or they couldn't tolerate it due to side effects. But the medication failed the person did not fail the medication. But I think it's also really important to note that it has to be an adequate trial of a medication in order to call it a failed trial. And an adequate trial means taking a medication at what would be a therapeutic dose for most people for an adequate period of time, and taking it consistently for that period of time. So using Lexapro as an example, because most people have heard of Lexapro, a really common antidepressant. If someone's on 5 milligrams of Lexapro and that's the only dose that they ever get to, that's way too low, right? I would want somewhere between 10 to 20 milligrams at least to call it, quote, a failed trial.
Okay.
If they're on 10 to 20 milligrams, but for a few days or for even a month, that's not enough time. There's a pretty good chance that if they had stayed on it longer, that it may have kicked in. Or if they're just taking it every other day, even if it's for the 2-3 months, that would be considered an adequate trial time. But they're taking it half the time, they're essentially getting a half of a dose, right?
Right. So they're kind of undercutting the data because it's not consistent to what we know to be therapeutic.
Yeah, exactly. So if somebody takes, again, a therapeutic dose for an adequate period of time and they're taking it consistently and it still doesn't work or they still can't tolerate the side effects, that would be a failed trial.
Okay.
But again, the med failed them.
Yeah. And that side effect profile can be messy and complicated because sometimes I've seen with a lot of people, it goes away after a couple of weeks.
Yeah.
And I've seen other people that tolerate probably way more side effects than they should before they say, like, I don't think this is working for me. So how do you kind of navigate that balance of what side effects are reasonable versus, like, let's try a different medication?
Yeah. The ones that occur at the very beginning are pretty common. So for SSRIs, again, these really common antidepressants, stomach upset is really, really, really common at the beginning. Headaches can be common at the beginning. Feeling either more tired or a little bit more stimulated or maybe a little bit like anxious or agitated can be somewhat common with some of them. So if it's one of these expected ones, I talk to my patients and I let them know this is what we can expect. This should go away after a few weeks if you can muscle through it. Or if there's some, here's how we try and mitigate it. If it's GI side effects, eat it with a meal, right? That tends to help. So I try and give them ways to manage through it. If it's absolutely intolerable, like they really can't get through the days with it, okay, we're going to call it, right? I'm not going to make somebody suffer. But this is something that I have seen that people will come in to my practice saying, they can't find a medication that works or nothing works or whatever the language is. And they've tried 5 or 6 medications, but only for a couple of weeks because they have side effects with it all. And again, it's...
So then for you, it's hard to gauge, is this a tolerance component on their end or a failure of the medication proper?
Exactly. And I think this is where the relationship with the prescriber can really make or break this whole thing. Because if a person starts a medication and their prescriber feels distant or unavailable, inaccessible, callous, right? They're not going to trust that they have a partner in this, right? That it's going to get better, or that it's going to work.
It's such a lonely experience and scary.
Yeah. If you have a prescriber who counsels you on the possible side effects, what to do about them, and says, hey, these are the ways to contact me if something's coming up and you have a question, if it's a symptom that I didn't talk to you about, but you're wondering if it's from the medication, I'm here. Shoot me a message. We'll troubleshoot, right? That by itself can be enough to get someone through that initial adjustment period where they may have not tolerated any meds before.
100%. I also think that's where therapy can be a really nice addition is, we're very familiar with seeing those side effects and can kind of help flag for people like, this one seems unusual, this one seems concerning, and even sometimes kind of tag the psychiatrist in of like, hey, there's a real big concern. And those 2 points of contact will sort of flag it more.
Mm-hmm. And again, those same psychiatrists who are more likely to make themselves available to their patients to answer the questions are also the ones that are probably more likely to make themselves available to the therapists.
Yeah.
When the therapist reaches out and says, hey, can we talk about this?
Yes. I often will sort of connect with psychiatrists before I refer someone to get a sense of how open they are to that collaboration. It would be lovely if our system allowed for more time and space for us to do that more easily.
Yes.
Yeah. Okay. So now we'll move into the subjective experience of failure. What I see a lot is, and part of this is the population I work with, but people moving into a more self-critical space as they're going through these transitional windows, a heightened sense of failing across settings, particularly in family and work, because what they end up doing is comparing themselves to who they were before the transition started. And so it's a completely different set of circumstances. But how do you approach this type of failure when you're guiding medication options?
I use this sort of similar criteria, right? I'm looking at actual functioning. But I think especially in the reproductive transitions, right? I think about someone who is going back to work after having a baby and them feeling like a failure in all realms. And sometimes there is a true depression happening, and we treat that with medication. Right? Again, it's the hardware. I am coming back to the symptoms to see if medication is going to be useful or appropriate. But this is also the really fun thing about reproductive mental health is that it's so multifactorial. And so even if I'm not doing actual therapy, I'm looking at their psychology behind it and how they're thinking about these different things. For the people that I think we both see who are used to being very high functioning, yes. Their brain is their superpower. Going back to work after having a baby is a very jarring experience.
Especially when you have to go back before your body is even healed.
Yeah, exactly. But they may have, their brain is totally different. The brain completely changes during pregnancy. And in ways that affect cognitive function and executive function, their working memory may be more challenging. Their, word finding and attention and concentration is different. And some of these things are evolutionary to help take care of a child. Mm. But when you are a working mom, that is not just dedicated to
those are very different roles.
Very different roles. And again, when your brain has historically been your superpower, it's very disconcerting for it to feel like your brain is not working. So I counsel people on that all the time. It's not necessarily that meds are going to help with that, but just understanding that their brain has changed and to be gentler on themselves and to manage their own expectations about it, I think is really helpful. And then I also find that particularly this group, they're trying to do everything at all times.
Yeah.
And they're at work and they're thinking about things at home, and they're at home and they're thinking about work. And it's so silly, but I find it so helpful. This quote from Parks and Recreation.
Great show.
For anyone unfamiliar, when the main character is trying to run her government job and also run for a political office, she goes to her friend and mentor, who says, never half-ass two things, whole-ass one thing. Mm-hmm. And that's not to say quit your job and be just do one thing, or leave your kid and never see them and just do your work. It's to say when you're at work, be at work. Just do work, right? It's not 100% possible to always do that, mm-hmm. but to make an effort and an intention behind that. And when you're at home, don't check Slack. Don't check your emails. Be at home, right? whole ass the one thing that's right in front of you.
Which I think this is a very therapist thing to say, but like that brings us into a space of grief of like, but I want to be 100% all the time for everything and I can't.
Yeah.
And that feels like failure.
Yeah.
Ooh.
Compared to who you were before. Yeah.
Yeah. When you were not trying to keep a small human alive.
Which is a daunting task. They're constantly trying to do the opposite.
Yeah. Yeah. And then to step away and do work and not have that constant feedback that like your child is okay and you are currently keeping them alive. Then we get into mom guilt and
oh my God.
Yeah, heavy things.
Hey, it's Dr. Booth. After we recorded this podcast, I realized that I had missed a really important point when we were talking about this topic of not half-assing two things, but whole-assing one thing. You know, when you're at work, be at work. I had forgotten a really important point, which is that in order to be able to do that, women need to have not just a helpful partner at home, but an equal partner, a co-partner at home or a co-parent at home who is not only willing to do tasks that are delegated to them or, you know, do something if they're given a list, but who are willing to take on some of that mental, invisible load of planning tasks, of noticing what needs to be done and taking initiative to do them themselves. You know, not just saying, I'll go to the grocery store if you tell me what you want me to buy, make me a list and be on call if I have a question, but they can look in the pantry, they can look in the refrigerator, they know what everybody eats, they can create a list from what they're noticing is not there, they can go to the grocery store and execute the whole thing themselves. And, you know, you can expand that to trash and dishes and children's clothing and pediatrician visits and planning summer camps, et cetera, et cetera, et cetera, right? These are tasks. This is work that is oftentimes done invisibly by women and oftentimes when they're at work during the day. That's when they have time to do this invisible labor. And so in order to be fully present at their job, women need to know that those domestic tasks are going to be done and that they have a partner who they can rely on to do those tasks and do them correctly and well. That doesn't happen overnight. That doesn't happen by accident. It takes a lot of communication, effective communication between partners in order to be able to make sure that that's all being done. But that is sort of an unspoken but necessary component to women being able to be present in the various aspects of their lives.
I'm wondering what other types of failure you find popping up for your clients.
Yeah. Again, in reproductive mental health, it's a bit of a minefield for this. And two situations immediately come to mind, which are infertility and breastfeeding. These are two reproductive related functions, right? Becoming pregnant and then feeding a baby from your body that we're constantly being told are the most natural things in the world, like what our bodies are made for and meant to do. And that implies an ease to them. And these things can be anything but easy. And when a person's struggling to conceive or they're struggling to breastfeed or chest feed, there's an immense feeling of failure. Their body is not working the way it's supposed to be, right? We can call that their body is failing in some way.
Well, that language makes me think about like just disability of any kind. Of like, there's lots of ways our bodies don't work the way they're supposed to quote unquote work. Yeah. And we have to figure out how to navigate it, which, brings up a lot of emotion.
Mm-hmm. And I think it becomes this conflation of the body and the entire person. That my body is failing, therefore I am failing. I am a failure because I can't do this thing. I can't get pregnant. I can't feed my child fully just from my breast or chest. Versus separating it out that I am trying my absolute hardest. I'm doing everything that I possibly can. And my body is not working the way that I want it to. And I think finding that separation is especially helpful.
Yes. And then figuring out how to find a path forward if that's not an option.
Yeah. And I, especially when it comes to breastfeeding, I really try in my own practice to take a very proactive approach to this. You know, when I have somebody who's pregnant, I'm starting to talk very early about what are you thinking in terms of, you know, feeding method for your infant.
Like, what are your expectations?
What are your expectations? What are your values, your goals? Are you somebody who thinks it's going to be a walk in the park and you know, haven't considered an alternative reality or scenario? What are your opinions or beliefs about formula? Are you somebody who's coming into this absolutely against formula? Or are you at least flexible, open to the possibility of it? Because even that openness or flexibility of thinking can make a huge difference going into it. If they don't need it, they don't need it. Great. But if a person who has very strongly held beliefs about formula goes into the postpartum and they are struggling to breastfeed,
it's a different level of devastating.
A different level of devastating and a recipe for very poor mental health.
Yes. As you're talking, I'm thinking about the way the software intersects with the hardware. If there's only one line of code and it requires a certain type of software and it doesn't match, that's going to cause much bigger problems than if there's multiple lines of code that can function depending on the software or the hardware.
Exactly. Yeah.
Those are really helpful ways to think about this and kind of reframe, coming in with like our ideal and then their backup contingency options versus there is one right way. And if that doesn't work, then everything else is a failure.
Yes. And especially with breastfeeding, we tend, as women in this particular society, we tend to conflate our success as a mother with our ability to breastfeed. Like, there's nothing else that matters. We could be doing everything else, quote unquote, right? We could be taking care of them at all other times of day in the most loving, nurturing ways. We could be attuned to them. We could be making sure that they have all of their needs met, that, you know, they're everything, right? But if we're struggling to breastfeed, we're a failure as a mother. And really digging into that, where that comes from, and combating those, you know, very rigid beliefs, I think is really helpful to do with this population.
That makes sense. All right. So if you feel comfortable sharing, this is when I like to ask the question, if there's a type of failure you've experienced in your own life or career, and how you worked through this failure and grew from it.
So the main example in my own professional life of a failure that comes to my mind is when I lost a patient to suicide when I was in my residency training. And as a psychiatrist, as a mental health professional in general, this is, you know, I think our ultimate example of
it's the thing we all
failing.
Fear.
Yes, it is our big bad. And that was at the time, you know, and still is, it's a devastating experience to have. If it was going to happen at any time, I was grateful to have had the experience when I was in training.
There's a lot more support around us in training. Yeah.
So much more. And I was very lucky to be at a very supportive program that was very proactive when something like this happened with a resident. So my attendings were, again, very proactive at reaching out, making sure that I was okay, if I needed to take any time off of clinical duties, giving me resources. One of the faculty at UCLA is actually kind of an expert in this arena, and has written papers on the topic. And so, making sure that I had access to those and to him directly to talk about
Beautiful. I mean, it's so hard to go through it and then to talk about it and to share it. And I thank you for being open to talking about it, because it is something that affects us so deeply, but is not something we, for understandable reasons, talk about very often.
Yeah.
And so I'm thankful that you said it was a him? Yeah. He's doing that work as well, because what a gift to the mental health community.
Yeah, absolutely. It made me feel less alone. When that happens, it in your own mind, it can feel like, oh my God, I'm the only person that this has happened to. No one else will understand. Everyone else is going to judge me and think that I'm a terrible doctor or terrible psychiatrist.
Why couldn't I save this person? Will be the question that everyone's asking.
Yeah. What did I do wrong what could I have done to prevent it? These are just all the questions that were swirling around in my mind. And through, again, all of the support. So it came from the top down. It came from the program, but my residency class, my colleagues were also incredibly supportive. And actually another one of them had a similar experience kind of around the same time, coincidentally. And our entire class organized a get-together one night to just sit and process and be there for each other. And so, what I learned through that experience was, first of all, the community of colleagues is indispensable.
Especially, I want to speak to, we feel deep grief when our patients die.
Yeah.
Deep, profound grief, because we have this very unique connection with the people we care for. And it's not something that we can necessarily go then grieve with the other people who knew the patient, because that's part of HIPAA and confidentiality and appropriate care. All situations are different, but then it is this very different form of grief, and having community where you can process it and share and experience that is invaluable.
Absolutely. And I also came out of it with a more humble view of myself and my role, right? I think doctors can develop this sort of complex sometimes that we have more control.
I have no idea what you're talking about.
What am I? Yeah, no one thinks that.
We're all perfect.
Yes. that we have more control and more influence than we really have. And this is the ultimate call to reality, that you could be doing everything in your power. And you could make all the right medication decisions, everything evidence-based. You could be communicative, you could everything. And this could still happen because I cannot be with every single one of my patients 24/7.
Yep.
And they're going to have thoughts and feelings and urges and behaviors that
you can't
are between
control.
Appointments when I can't control. I'm not there with them. And they may not tell me about it, even in the moment. They may not reach out to me and say, hey, doc, I'm feeling this way. What should I do? Right? I always tell them that they can and they should reach out to me. At the start of every, new relationship, I tell them this is what to do in emergency. This is how to reach me. If you can't reach me, there's 911, there's the ER, all of the safety things. And we check in about safety when someone's at higher risk. We do all of the things. And they may not utilize those resources.
Yeah. Yeah, you can make everything available, and it still may not be enough.
Yeah. And I think it was also realizing the amount, my own personal time boundaries, right? Having that happen, there is sort of this initial urge to, okay, I'm going to be available 24/7 for my patients.
Yeah.
Literally all night, after hours, no matter what, for everybody, I will make myself available. And for some people, they have the bandwidth to do that. I question that a little bit, right?
That's a subjective judgment.
Yes.
Yeah.
But that, recognizing that even doing that is not always going to be enough. And that the only thing that will be compromised is my own mental health, my own amount of bandwidth that I can offer to my patients.
Which then affects all of your patients.
Exactly.
Yeah, I think especially we do similar work, but also your field is very different because you have so many tools that literally save lives. And so I think some of when you were talking about the things that can develop for doctors, it's like there is an element of if we find the right combination of things, we can save lives. So there's this expectation of I have control over death.
Yeah.
And these situations is a reminder of we have tools and we cannot control everything. And that's a bummer.
Yeah.
Yeah. Yeah. It's very hard to sit with. And so I think leaning into the control and even going into that problem-solving mode, I'll be available all the time, I'll do this, we'll have this after-hours program. Again, tools. But it goes back to that, we can't logic our way out of death. We can't control everything. We can't be all things to all people. And I like the term you used of humbling, because that is ultimately the humbling thing. There's no way we come out of that without having to hold that sorrow and our own limitations.
Yeah.
Yeah.
And just, especially when it comes to other human beings, right? I think this is, again, the control over death is what I learned here, or the lack of control over death, but also just the lack of control over other human beings' behavior, right? And this is something that I think our shared clients, and even the ones that we don't share, this is something that we see them wanting to do constantly.
Control helps us feel less afraid.
Yeah.
But life is just scary sometimes.
Life is just scary sometimes. And you can, learn your own psychology. You can learn your own, reasons for acting and thinking and feeling and behaving the way that you do. And can start to understand why another person might think, feel, act differently. But you cannot control their behavior or how they act or feel or think. And I know there's been so many times when, I have a patient who said, I could be happy if they would just say sorry. Or if my mom just started, treating me completely differently.
If she was a different person.
Completely different person.
Or I need the apology to be phrased in this specific way.
And it's a less life or death, version of it, but it's essentially the same thing as, recognizing our own limitations to influence the behavior of others. And finding our own way to have peace despite what other people do.
I like the way you phrase that, because that finding that peace about not having control is something profoundly liberating.
Mm-hmm.
Because then you really only have to worry about what you have agency in.
Mm-hmm.
And that takes a lot of pressure away.
Yeah. The pressure and the, tendency to please people.
Mm-hmm.
If I act this way, then they'll like me and I'll be happy.
And everything will be okay.
Everything will be fine versus just, well, what makes me happy?
Yeah. This is aligned with my values and it's the best I know how to do in this moment.
Mm-hmm.
Yeah. Thank you for sharing that. Can I ask how it changed the way you practice?
I think in the moment, it changed it to where I was much more risk averse than I was, in the immediate aftermath, right? It changed it in a certain way. And then as I grieved and processed more, it started to change again. But I think where I am now, that was several years ago now. I now practice in a way that, again, aligns with my values, which is being communicative and accessible to my patients and warm and all of that. I'm very conscious of safety, right? Checking in about safety. If someone has a history of either self-harm behaviors or any kind of suicide attempts in the past or anything that we know raises their risk, checking in about that and making sure that there's not an increase or an intensity of those things happening. But then also maintaining my own boundaries.
Yeah.
Because
keeping yourself healthy.
Keeping myself healthy. Because I can do all of those things in session, and that's the limit to which I really can control things.
Mm-hmm.
And if I'm half-assing two things and I'm at home and constantly checking my messages every time one comes in, or if I'm checking my phone, my daughter is going to see and feel that absence.
Mm-hmm.
And that's going to feel really horrible. Or if I can't ever, turn off and do something that I just do to relax and enjoy.
We all need hobbies.
I'm going to feel that. Yes, exactly. Yeah. And so, I have an automatic message that goes out whenever somebody sends me a message to my practice, whether that's through my portal or I have a texting app, HIPAA compliant texting app, but everybody gets an automatic message that says, if this message is coming in, I respond to messages Monday to Friday, 9 to 5. If you're having an emergency after those hours, don't wait to hear back from me. Mm-hmm. Call 911, go to the ER.
Take care of yourself.
Take care of yourself.
Yeah.
Right? Or call 988.
Yeah.
The suicide hotline. Because I am available to you. I am your doctor, but I also have my own boundaries, my own limitations.
Mm-hmm.
And it took a long time to feel comfortable setting those and maintaining those.
It's super hard.
It's really hard.
Because in the same way there's mom guilt, there's like doctor guilt. Like there's people who need us, and I'm going to go make a sandwich? I don't know. That doesn't feel right. Yeah.
Doesn't feel right. And that is drilled into us in medical school. That is the culture that you don't turn off. You are a doctor 24/7. And there are some doctors who do live that way. I think less so in psychiatry because we learn about boundaries.
Fair.
Boundaries and mental health are not concepts that other medical specialties get a lot of exposure to or training in their residency programs, where it's like all we learn. But that life would not work for me.
Yeah. I think so much about being an effective doctor is also understanding like what you can do well. Mm-hmm. And in the same way that like you and I have both learned a lot about boundaries so that we can be a better doctor, There's a lot of doctors who it's like their field, it's not an option. Yeah.
But there's a self-selection that happens.
Yes, there is. Yeah.
To that. If you know you're a person that your work will always be more important to you than anything else, and the work itself or the prestige or whatever it is, right? That will always be first priority. Then yeah, go into neurosurgery.
Yeah.
Like those are the people that will choose that specialty. It is self-selecting. You're not really going to find many people going into medical school and going into the match process who talk about work-life balance, who are choosing
like emergency medicine.
Even emergency medicine, actually, it's shift work. Like they go in, they do the work. It's really intense. It's very intense, but there's no, like, they sign out their shift and it's the next.
They're not carrying them over with them.
Yeah.
So it's a different type of boundaries.
Very different. Yeah.
I appreciate that.
But like the surgeons who are called in the middle of the night, or, like ICU, pulmonary critical care doctors,
Yeah. Yeah, people who are on call.
Yeah. Mm-hmm. Exactly.
Yeah, that was something I learned in my training, being on crisis call. Like, I don't function well if I don't sleep. And I don't sleep well if I know that an emergency might be coming at any point. And so, like, I am not very effective in my life in general if I'm doing this work. Mm-hmm. Yeah. Which I can see as a failure or as just information of where I belong.
Exactly. That tension is, I think, where a lot of doctors can become really burned out and unhappy, is they ignore their own internal signals and what they actually like and want, and pick specialties based on, certain other factors, whether that's prestige, whether that's they liked this one rotation in med school even though it doesn't align with certain other values or whatever it might be. But somewhere down the line, that tension really rises to the surface and they're really unhappy in the specialty or the career that they've chosen. And then you see a lot of doctors leaving clinical practice because of it, unfortunately.
Yes. And combine that with the faults in our system. And that's
a whole other podcast. That's a whole other failure podcast.
Systemic failure. Who do I interview for that?
I could give you some names come to mind.
Send me an email. Wonderful. Thank you so much for sharing your expertise today. I loved it.
Thank you so much for having me.
Yeah. If people want to know more about what you do, or if they want to work with you, where can they find you?
Best place to learn about me or get in contact is my website, www.brittanyBoothMD.com. I am also somewhat active on Instagram. I try and put up some educational content, sometimes funny content.
Some cross-stitching.
My embroidery project.
Embroidery.
There's no social media strategy or expert behind this. It is just whatever whim comes to me at the time. But it's Dr. Booth.
Beautiful.
On Instagram.
And I'll link all of those in the show notes as well.
Okay.
All right, Dr. Booth, thank you for joining me today, for sharing your knowledge and expertise. It's so helpful to know these things and to have some resources of where people can go when they need help. And thank you to everyone who listened today. Remember that failure is a necessary part of growth. So keep failing, keep learning, and keep growing. Special thank you to everyone who contributed to this project. Consulting producer and editor, July Diaz. Producer and graphic designer, Ben Castle. Logo art by Josie Huang. Theme music by Daniel Rogers.